soon as it does, I'll kick it live. And I'll give it a minute or two. Okay, it should be coming up. Hello, we're just giving a few minutes to come full stream.
You hear it?
This is a sound check for the audio. Okay, I think we are ready now. Good evening. I'm Dr. Travis McCoy with the Piedmont Reproductive Endocrinology Group. I am a reproductive endocrinology and infertility specialist, and part of our field is very wide. We cover female infertility, but I have a very personal interest and have had many years of additional treatment and also other training specializing in the male aspect. And I really enjoy that part of my job. Males account for approximately 40% of my practice. And I think I have a very good understanding of merging both the male and the female aspects together when it comes to fertility. You really, it's very difficult to treat one side without treating the other. And you have to look at both of them as a couple, as a whole, before really being able to make a treatment decision. So tonight my idea is to give some overview and discussion of male fertility and really take questions from the general audience. I have my helpers Julie and Alex here with me tonight who will be reading out some questions as people live chat them in. So we're going to start just by discussing male fertility. Male fertility is an extremely common problem, and it's really well underappreciated. In general, it's estimated that about 7% of all men may have a fertility issue. And when we see couples as a whole, it can account for a very large portion. We think that we see an isolated male issue in about 30 to 35% of cases. And there's at least a male component in about 50% of the female couples that we see. So this is extremely common. And this screen just shows a breakdown of commonly seen tubal issues, but males accounting for about 35%. And in a lot of time, at least the male component is also coexistent with a female component. So that's why we really recommend one of the first investigations is to do a male evaluation, starting initially with a semen analysis. It is by far the simplest, easiest, and cheapest part of the entire fertility workup that can be done. It's very simple and it's very easy, and it saves a lot of wasted time. It's very common in the men I see who have issues that they've been trying for several years before anyone ever bothered to look at the male side to see if they may have had an issue. And sometimes that's completely wasted time. I tell men it's a few times a week, at least 2 to 3 to 4 times a week. I see men who have no sperm whatsoever. that is unfortunately common. About 1% of all men may not have any sperm. And this is something that he would never know in his entire life until they get tested for it. So starting out with the males is definitely one of the simplest, easiest things to do, and is where we really start. The male is much simpler to investigate, and that's done with a semen analysis. A semen analysis is a rough ballpark view of trying to see if there may be a fertility issue. And in a semen analysis, the man gives a sample through simple masturbation, and we look at the sperm under a microscope. And we're assessing the numbers of sperm and how well the sperm are moving. Those are primarily the main issues that we're looking at. That helps us to really judge what the treatment options are and where to start. And there is no single defined value that clearly states that he is fertile or infertile. If the numbers are very, very high, then it's very unlikely he will have a fertility problem. But if it's very, very low, there's definitely a problem. But there is a very large gray zone in the middle that he can look somewhat okay, but the sperm may not function normally. So generally, we're really just trying to point if there's an obvious issue and where to start. When we look at a semen analysis, the main things we look at, again, are the number of sperm and how well they're moving. And the primary number that we will look at is called the total motile count. That's how many moving sperm there are in that specimen. And that's a calculated number. You take the volume and multiply it by the concentration, tells you how many sperm are there. And then you multiply that by the percent that are moving. It tells us how many moving sperm are there. Now, semen analysis is a rough ballpark view, and there can be a lot of day-to-day variation. Numbers can vary 50% or more from one day to the next. So anytime we see any one semen analysis, one of the questions that always come up is this his average, or is this him on a good day, or is this him on a bad day? But it at least gives us an idea. It may take several analyses to figure out what his true average is, but at least a single one generally gives us a good ballpark view of where to start. So when we look at sperm and the treatments that we can use, this total motile count is by far where we start looking at. And normal numbers are somewhere in the above 40 million range. And just from a male perspective, couples could probably just have intercourse to conceive. This is not taking into account any female sides. In the low range is in the 15 to 30 million range. And in these situations, if we cannot help him and make those better, then that couple may benefit from what's called inseminations. Inseminations are where we take the sperm and concentrate it back up, and in conjunction with the female of figuring out when she's ovulating, put the sperm directly back in her uterus. This both concentrates the sperm and gets the best moving sperm inside the uterus to give them a head start. But even in this case, we still need to have fairly good numbers in order to do inseminations. So if we have very low sperm counts, really less than about 10 million, insemination success really drops off to near zero. And those couples, if we cannot help him, are best served by going directly to in vitro fertilization. IVF or in vitro fertilization is always the backup plan. As long as we have some live sperm, IVF can be done. So when I look at the males from a male perspective, I really ask, can I get them out of that category into another simpler, easier category? That's ideal. Some men we can help and get them into that better category, but others they can't, and we have to resort to IVF as a fallback. Now, the one thing to take into account with this is that these numbers can somewhat be deceptive because this counts percent of sperm that are moving, and moving sperm can be defined in different ways. Sperm are counted moving as both the sperm that are moving very actively as well as the sperm that are barely wiggling their tail and not really doing anything. And these sperm have vastly different capabilities of being able to fertilize an egg. So this number, this raw total motile count, is really tends to often overestimate the number of good sperm there. So often it actually even looks worse than the total motile count shows. The real question is, what is the sperm's ability to fertilize an egg? And we do not have a specific test of that. This is our best estimate. There are some other tests in the works, some of which we participate in some research to try to see if we can find that gold standard test of sperm fertilization capability. When we process a sperm for insemination, you have to wash out and separate the sperm from all of the non-sperm chemicals. And in this washing process, you lose a lot of the sperm that aren't moving well and the sperm that really aren't going to get the job done. So what it leaves you with are the really good functional sperm. But you lose a vast majority of the sperm. You may lose 90% of the sperm in that situation. And so I tell people that the insemination prep is really the harsh reality of what the sperm really look like. And that's really the numbers that we judge. After sperm is processed for insemination, the best success rate comes at levels of about 8 million sperm or above. After you get up to about 8 million, success chances that cycle are maximized. And below 8 million, there is a direct line correlation of number of sperm and chances of success. There's not any number below which you do not see any pregnancies, but the success rate gets to be really, really low, under 1 million. I'm usually will be open to trying inseminations down to about 500,000, because sometimes if the female is very fertile, she may be able to somewhat make up that difference. But if we're consistently under 1 million and we try a couple times and we're not successful, those couples really need to consider going on to in vitro fertilization. So once we process it, the majority of couples will have in the 2, 3, 4, 5 million range. After the insemination, honestly, if they end up having 50 million sperm after the preparation, they probably didn't need the inseminations to begin with, from the male perspective. So these numbers are where we first determine the category of treatments of where to stand. So if a guy comes in and he has an abnormality of his semen analysis, the first question is, can I fix him or not? And the real question, you have to look at the couple's story and that guy's story. Many times he may have never ever been assessed and often has never fathered a pregnancy. And so I only know his semen analysis of where he stands now. I don't know what he was in the past. No one has a semen analysis at age 18 to know what his full potential was. So we're trying to guesstimate from where we see him now, did he used to be better in the past? And if so, can I get him back to that point? So the initial evaluation for a male includes some hormonal evaluation. We are looking at the brain signals that get sent from the brain to the testicles, and then the signal from the testicles back to the brain, testosterone. A testosterone level by itself is not very helpful. You have to look at all of those hormones. When we see issues with sperm counts, they generally will fall into several categories. When we see generalized low sperm counts, in order of frequency, generally first and foremost is an inherent low testicle production. That's always been there. A man is born with a certain capability of his testicles, and that potential doesn't usually change throughout his life. And so in many cases, he just had a lower production of sperm to begin with. In some cases, the second most common thing I can see is that in many cases, there may be low brain signaling, where the signals from the brain to the testicle are not getting sent properly, and so the testicles are not working to their full capability. And then lesser common, there can be some other issues, something that's called varicoceles, which we may address later, which are basically dilated veins around the testicles that can hinder optimal sperm production as well, but it's a much lesser common issue. So the top things we see is an inherent issue with production or a low brain signaling. I cannot change the inherent function issue. However, I can change the low brain signaling to really crank up the function of the testicles to make sure they're running full speed. So the blood work that we do helps me assess whether or not he could be benefited by medications to get the testicles to run to full speed. The testicles have basically two functions. They make testosterone and they make sperm. These two functions are related, but they're very separate as well. If you are not making normal levels of testosterone and not functioning at full speed, you are not going to optimize your sperm levels. However, just because I can overdrive the testicle to make the testosterone levels come up, do not always mean that the sperm levels will come up as well. But definitely, if it's not running full speed, you're not going to have the best sperm that you can. So we do the blood work initially to see, can medicines benefit him? And if so, these medicines can be very simple, easy, and cheap medicines, usually with very minimal side effects. Most of the medicines we use start out with simple oral pills that simply make the brain send higher signals to the testicles to basically scream at the testicles, to make them run full speed, 100%, so that you at least know you're getting the best sperm production you can in that situation. Often you can demonstrate the effectiveness of that by looking at blood work in a couple weeks to make sure it's working, but it takes a while to make new sperm. Technically, it takes between 70 to 80 days to make new sperm. However, it takes longer for them to work their way all the way out to really see a difference in a semen analysis. So the soonest that I will see a difference in a semen analysis is about 4 months. So if those medicines are working, then we generally wait, and that's about all you can do is wait for about 4 months and then recheck a semen analysis. You may continue to see improvement further upwards of 7 or 8 months on the medications. But in general speaking, if it's not changing by 4 months, it probably won't. So a lot of times that at least lets us know if we're moving in the right direction to get out of those lowest categories to the higher categories, and hopefully can start doing some other treatment, something like inseminations. We do not have a direct marker of sperm production, and there's not an easier and simpler way to see if sperm are being produced. There's no blood work that tells us directly that he's responding. You can't look with an ultrasound or any kind of other imaging and tell if sperm are being produced. It really just takes the education of knowing the hormone levels and the experience of how other patients have responded to estimate whether or not he may benefit. Even then, a lot of this is patience. It does take about 4 months to see a difference. So I tell patients, I know that's a long time. Patience is a virtue, but in many cases it can make a significant difference. And if they will just wait, sometimes it can make a real difference in their situation where they don't have to do more aggressive treatments if they didn't need to. So that's where we start in a man who has low sperm counts. I did mention that some men can have what's called a varicocele, and this is diagnosed by examination. It is not diagnosed by ultrasound. And the problem with varicoceles is that many men have varicoceles. As many as 25% of all men will have them. However, the effect on the sperm is a lot less than that. Many men that have small ones, it has no bearing, only if they're quite large and significant. In those cases, and really they're very select cases, those patients might benefit from a surgery, but you have to look at the situation as a whole. In general, the number of guys I see that could benefit from a varicocele surgery every year is in the single digits, 3-4 guys a year of all the men I see. Actually, it makes a difference in where you go. If you raise the sperm counts up, but you're still in the IVF category, then that really wasn't helpful. Or if you're in the insemination category and you're still in the insemination category, again, that's not helpful. So varicoceles, most of the time, are just a red herring that confuse the situation. And just because somebody tells me they were diagnosed with varicoceles, that means nothing. And they should definitely not have those repaired until they really get a second opinion from a male fertility specialist. That goes back to another thing about the male fertility. Many times, many patients get sent to a urologist, a general urologist. Urologists, during their training, do not get much training at all about male fertility. They actually get very little. Just as in a regular GYN doesn't get a lot of training about female infertility. And most general urologists know very little about fertility, and they end up doing way too many tests on people and put them through sometimes many times invasive procedures without ever giving them an answer or even knowing how to look at it in perspective. You really have to look at the couple, because if, yes, and some male fertility specialists who don't treat the females may just focus on treating the male, and they may put him through things like varicoceles surgery to help his counts, but totally missing the fact that the female has a separate issue. And sometimes she may have issues that are as big of a problem or more than the male. And if that's the case, then it may not matter much what we have to do. Maybe we have to resort to more aggressive treatments like in vitro just for the female issue. And then it doesn't matter about the male. So you really have to look at the couple as a whole and seeing if we can really help them and benefit them. So that's where we kind of start with low sperm counts. Some of the more complicating issues sometimes come up when we see a guy that has no sperm or near no sperm. And this is my everyday. I see this at least 4, 5, 6 times a week of guys that have no sperm whatsoever. And this really raises a question. And even going back to the low sperm count, some guys, will say, well, I fathered a pregnancy several years ago. Well, a lot can change in a few years. If he's fathered a pregnancy or had a semen analysis in the last 1 or 2 years, generally that's not enough time to change. But things can really change as guys get older. I mentioned that low brain signaling. That becomes extremely common as guys get in their mid-30s and above. And above the 40s and above the mid-40s, nearly a majority of guys will have a low brain signaling issue. So many guys, though, come in with no sperm. And if they have never had an assessment before and they've never fathered any children, the question is, what are the odds? Can I help it? And it's less likely I can help those guys. Generally, low brain signaling issues will usually lead to very low sperm counts, and only rarely will it lead to no sperm whatsoever. So most of the guys that have no sperm have always had no sperm. They just never knew it. Of guys who have no sperm, many of them can actually have sperm inside the testicle. What we're trying to really assess is what is the odds that he has sperm there, and can it be used, and what are the options. In general, across the board, when a guy has no sperm, about 50 to 55% of them may have sperm in the testicle. So the workup for these guys involves, again, hormonal testing to see if the testicles are optimized, examination. The size of the testicle tells me a lot about the cause. And that helps us assess where to go. In some cases, we need to do specialized genetic testing, because about 15% of guys who have no sperm may have a genetic issue. And that helps figure out the odds of, are there sperm there, and could we find sperm to be used? So the male workup is about the same. The harder part is the discussion of where couples want to go. Options are, always an option is use a sperm donor. When it comes to donors, just as it does with females, no one wants to use a donor, and that's generally their last resort. But really, where a couple lies in the steps of extremes of where they will go one way or another depends on the couple. Some couples are fairly open to donor. He says, hey, this is, if I try it with my own sperm, this is going to be a difficult road. It's going to be an expensive road, and my odds may not be that great. And it's not that big of a deal to me. To me, it's how I raise my child. That's the most important thing. And they will choose to go to a donor. Whereas I have other men and couples that say donor is out of the question. If it meant that I had to do a donor or never have a child, we will never have a child. And that's really their decision. And so some couples will go to all extremes to see if they have sperm, and some will not. The only way to clearly establish in those cases if there are sperm is through a testicular surgery procedure, which I do, called a microsurgical TESE, testicular sperm extraction, a micro TESE. This is not a general testicular biopsy, and this is not a conventional TESE, T-E-S-E. This is using high power magnification to search through the testicle looking for sperm. The inside of the testicle is full of tubes. I'm going to pull up a slide here just a minute. This is a slide of a testicle. The main body of the testicle and the structure on the outside is called the epididymis, but the inside of the structure is made of very, very fine tubes that are much like superfine spaghetti. Each tube is the width of maybe 2 hairs wide, and the sperm are made inside these tubes. But the production is not evenly made throughout the entire testicle. The production can be very spotty. So in some cases, you can have sperm in one area and not in another. And many times, like I said, there can be sperm there. They're just not being made in enough numbers and in categories in order to work their way out. So by going through the testicle, this is done under general anesthesia. He's put asleep for it. And searching through the testicle, you're looking for tubes that may have sperm. The tubes that have sperm are a little fatter than the ones that don't have sperm. It's very minor. And once we find tubes that look promising, take out a very tiny microscopic section, chop it up under the microscope, and look and see if we have sperm. If you find sperm, then those sperm can be used to fertilize eggs. Now, when you find sperm, you only find very few numbers of sperm, so it has to be used with IVF. And that sperm can do okay. It will not do as stellar as great healthy sperm, but it can definitely do okay. So you have to really take into account the female aspect too. This is much more successful the younger that she is. Doing this in a couple where the female is much older and her eggs may be of lower quality is going to yield a much lower success overall. So that procedure, a micro TESE, is the mainstay procedure in guys that do not have sperm. It is important to do some of the other genetic testing, as I mentioned, because sometimes there are some specific genetic tests that if those are present, then that tells me for sure that unquestionably he cannot have sperm there. And so I would never do that procedure. So that's the option for men who don't have sperm. Now, in men who don't have sperm, the number one reason is inherent low function. There can be a low brain signaling, and sometimes it's two problems together, but rarely does a low brain signaling fully account for not having sperm. The third factor is some guys can have a blockage. Blockages can occur somewhere in the plumbing system of the man. When we look at the structures, we have on the bottom of this slide a testicle. The tubes coming out of the testicle merge together to form the epididymis. The epididymis is the housing structure of the sperm, and then that turns into the vas deferens. This is what gets cut when a guy has a vasectomy. And so in some cases, that anatomy is not normal. Many times guys can be born that way, and he can have a blockage somewhere along that point. And so that can be figured out through the blood work and the examination pretty accurately. You can't always determine everyone, but I can pick out the majority of the guys who have a blockage ahead of time. Blockages can also be acquired as well. Having a sexually transmitted disease, such as gonorrhea or chlamydia, particularly if it lasted for a long time, can set up what's called an epididymitis, which is an inflammation around the testicle and the epididymis structure. And those tubes in that structure are very, very delicate, and they can get scarred from that. So I have had several guys that actually may have had kids at one point in time or had sperm at one point in time, but somehow they've acquired a blockage. But blockages are the least common cause, so that's kind of a diagnosis of exclusion. But in those guys, they should have good sperm being produced. So they should have very normal sized testicles. The hormones should be all normal because they're making tons of sperm. The sperm just can't get their way out. So in those guys, getting the sperm is pretty easy, though you still have to combine it with in vitro fertilization because you cannot get enough sperm out to do an insemination. But they have, of all the reasons for having no sperm, a blockage is by far the best. It has very good prognosis, and the quality of that sperm is very good. One of the other main causes that I see of guys that have no sperm is the use of testosterone. Many guys use testosterone, sometimes being prescribed by a doctor legally, and other guys illegally. There are some testosterone type supplements that can actually be purchased on the internet that can be strong enough to stop sperm production. Well, isn't testosterone a good thing? The more testosterone, the better. Not exactly. When a guy takes testosterone, the brain sees the testosterone in the bloodstream, and it does not know where the testosterone is coming from. All it knows is there's lots of testosterone. And the signals between the brain and the testicle are much like a cruise control in a car, controlling the speedometer and the gas pedal. So if the car is going fast, like if you're on cruise control and going down a steep hill, the car backs off, pushing down on the gas pedal. So the brain sees all this testosterone. It doesn't know where it's coming from. It's happy, and so it cuts off all of its signaling to the testicles, and it can completely shut that off. And then the testicles shut down their own inherent testicle production, and sperm follows. The effect is variable depending on the route of testosterone. Injectable testosterone is by far the worst, and injectable testosterone almost unquestionably stops completely all sperm production, and it does so very quickly. In the vast majority of the times, this is reversible, though it is reported that we think that with long-term use, such as when guys abuse it for bodybuilding for many years, it sometimes can cause irreversible damage. But this is a very common cause. Sometimes the female partners aren't even aware that he was using testosterone. I've seen that happen before. So you have to have a real frank discussion. And I don't really care that he was using it, but then I just have to talk about how we have to get him around it. I can turn production back on, but when he comes from that dead halt, it can take a minimum of generally 5 to 6 months to get sperm back, and you may not see full sperm recovery for 8 or 9 months. And so it can take a long time. Many guys got put on testosterone because they were told they had a low testosterone to begin with. And that's just because the testicles were underfunctioning naturally. And that was that natural decline I was talking about with aging. So that's extremely common too. So testosterone supplements in any way, shape, or form, completely bad, generally will make a guy, I hate to even use the word sterile, but that's the word to use. So it stops all sperm production. But the good thing is that's generally reversible, though it takes some time to get them back. Many guys, because they've been used to feeling good on testosterone, worry about, well, how am I going to feel if I come off of it? If you just stop it, the testosterone level does drop dramatically, and they often will feel bad. But we have methods where I can use medications to transition him over to make his body make his own natural testosterone, to usually get him closer to feeling more normal. So those are the most common causes of lack of sperm that we see in that evaluation. It's a little complex in these discussions with the men trying to figure out what to do. Do we go the route of IVF with a sperm retrieval? And what are the odds of finding sperm? And sometimes it can be very good odds, and sometimes the odds aren't that good, and they may have to really consider using a donor as a last resort. So it's a complex discussion that really takes a long time to decide what is best for that couple. And they really ultimately have to decide what's best for them. And that often comes down to what is our tolerance of using donor sperm if needed. One other topic I'll go on to before we take questions is the topics of vasectomies. We see many guys who had children and chose to have a vasectomy, thinking they would never have any more children. And then lo and behold, they get in another relationship and she wants to have children, or they decide they want to have children together. And they come to talk about their options. The ones that do the best are the ones that come to talk about their options ahead of time. And when you have that situation, there's a lot of things to take into account. Options, basically, if a guy's had a vasectomy, are either having a vasectomy reversal or going through in vitro fertilization with a sperm retrieval. Choosing which one to go to is somewhat complicated, but it's not that difficult either. I see many guys who went and had a vasectomy reversal only to not bother talking to us to begin with, and then find out that it was not successful, And generally, the reason it's not successful is he was a very poor candidate and was talked into having a procedure that he never should have had in the first place, that the odds were terrible, and he wasn't given the exact truth about it. Or finding out she had complicated issues too. And so having a sperm a vasectomy reversal did not overcome any of her issues, and they still have to do more aggressive therapy. I do send guys for vasectomy reversals. Now, being a specialist that does specialize in male, I do not do vasectomy reversals myself, and I'll explain why. I have had a lot of surgical training. Complex surgeries are one of my specialties. I love doing the male procedures, the sperm extractions, the microtesses, the what's called a MESA, epididymal sperm extraction. But in this situation, when guys have had a vasectomy reversal, sometimes they can be straightforward. As simple as when I do a tubal reversal on a woman. Not a big deal. I can take care of that at any point in time. And there are a lot of people that do those. General urologists do them, though really I would never have one done with a general urologist. Some people kind of self-specialize in vasectomy reversals, and these are unfortunately the ones that advertise a lot on the internet. The ones that advertise often I find aren't the most capable ones. When a vasectomy has been done, the vas deferens is cut and separated. The procedure of simply putting back the vas deferens to each other is not that difficult of a procedure. I could do that. The problem is that many times the longer the vasectomy has been there, when this is cut, there becomes a pressure that builds up upstream above the blockage. And this structure that we talked about, the epididymis, this epididymis has very, very fine, delicate tubes. Now, the heavy tubes of the vas is easy to put together, but this epididymis tubes are extremely small and extremely delicate. And if a guy has a blockage above in that epididymis, you do not know it until you get there at the time of surgery. Then they need what we term a bypass procedure, which is technically termed a vasoepididymostomy, taking the vas and connect it to the epididymis. That is a terribly difficult procedure to do. And honestly, there's probably less than a dozen people in the entire country that are good at doing that. And the longer a guy's had the vasectomy, the more and more likely the odds are that he will need that procedure. And if he needs that procedure and he does not have it done, if they simply put the ends of the tubes together, he will not be successful. It's going to fail. And once a guy starts to get above about 5 years, the odds become really significant that he needs to have that bypass done. And so what happens when I see guys that are 10 years out and go to have a vasectomy reversal? They say they see no sperm, they put the two tubes together, they charge them $5,000, and it's totally unsuccessful because the doctor didn't do the right procedure in the first place. So if you're researching a doctor, the important things to do are to make sure the female doesn't have any significant issues. And really, the better assessment is having her be assessed by a fertility specialist rather than a general gynecologist. But if it's less than 5 years, really any of the people who do vasectomy reversals ought to be okay. Once you start getting above 5 years and definitely above 10 years, I would only, if it was myself personally, I would only go to someone who is capable of doing what's called a vasoepididymostomy, the bypass procedure. If you ask that doctor if he does the bypass procedure, if he says no for whatever reason, I wouldn't dare attempt a reversal with him because he's not capable of taking care of you if that's what you need. And you don't know till you get there. And if you aren't prepared for it, then it's too late. So there's only a handful of places I would refer guys to. There's some referral centers in really Atlanta, over at UNC. Those are guys that are really trained to do that procedure. There's really no one in South Carolina I would trust with a vasectomy reversal, unless it's less than 5 years. So if a guy's had an unsuccessful reversal, then the option is getting sperm. And sometimes I still try to check hormones to make sure that the brain is functioning normally. Of the guys I see that have had a vasectomy that are choose to go to IVF, over 3/4 of them have low brain signaling and need to be treated medically before I can even get sperm out of him. And that takes a little while. So a vasectomy reversal can be a reasonable option. It's generally best if the female's under 35. Best if she's been very fertile before and has no other medical issues, no history of any endometriosis. Endometriosis would be a big red flag. that I would never do a vasectomy reversal. And if he's really had a vasectomy less than 5 years, or if it's been more than 5 years, that he really goes to a respected center, and that's a doctor that does the bypass procedure or a vasoepididymostomy. If the doctor doesn't do a vasoepididymostomy, I would never have a procedure with him. So that's extremely common, but other guys wish to go on and do IVF with a sperm retrieval. That sperm retrieval is tremendously easier than a vas reversal. And most guys tell me that sperm retrieval process is easier than the original vasectomy was. I do sedate them for it. You can almost do it under local medicine, but that area is difficult to get fully numb. And I tell people I don't want it done on myself if I wasn't numb. So I do sedate you for it. Generally takes about 45 minutes, and it makes a very small little incision, generally about an inch long, to get sperm out of the epididymis structure or out of the testicle. In recovery, the guy's down a couple days and then he's back to work. And so generally, almost all the men tell me it's easier than the original vasectomy was in the first place. So that's a very good option in that case. So I have rambled on now for about 40 minutes. So I've tried to address some of the questions that may come up, but I'm going to take some questions from my lovely assistants, Alex and Julie, of some questions they've put together that have been asked.
Okay, so a lot of questions were sent in to us privately, but we do have some. One is, do you have any experience dealing with men that have an inner stem?
An InterStem is a electronic device that gets placed into people for different reasons. It can be used for the bladder. It can be used for pain issues. One other issue that we see sometimes are guys that are not able to have an ejaculation. This can develop as a consequence of diabetes or as a consequence of a spinal injury where he's paralyzed. And they're not able to ejaculate. In those guys, it depends on the reason the InterStem. If the InterStem is used for an issue like that, multiple sclerosis, for bladder therapy, or an injury, sperm can definitely be retrieved in guys that can't have an ejaculation. And that could, and the workup is the same. It's making sure they're hormonally normal. Anytime a guy has a medical stressful issue, it can shut down the brain signaling, so you try to maximize that first. Then the sperm can be obtained out of the testicles. The fact that he has an InterStem in place doesn't really affect anything we do and wouldn't change the evaluation.
Okay, and another person asks, is there a way to fix morphology/motility issues?
Morphology is something that is included in a semen analysis, and morphology looks at the percentage of sperm that are normal. This is required to be part of the report, though it is something that really we do not pay attention to these days. There are a lot of arguments in our field that morphology should not even be reported because it's not really even relevant in what we do and doesn't almost ever change our decision making. The majority of the sperm a guy makes are abnormal. What we consider normal is if 5% or more actually look textbook normal. So that means 95% of the sperm are deformed. And some guys can have a quote-unquote low percentage of morphology. Generally, you see it in guys that have overall sperm issues anyway. So the morphology itself is not an issue. The morphology, the sperm that are abnormal don't fertilize an egg. So it's no concern whatsoever about having birth defects or genetic defects because those sperm can't fertilize an egg anyway. So the morphology rarely changes what we do. Multiple studies have shown that it is not a good predictor of natural fertility or with inseminations. And there's a lot of error to it. That number can vary as much as 2 to 3% just by repeating the analysis. So the morphology, I didn't even mention it because we almost never take it into account. I recently rewrote our sperm interpretation, and I wrote a nice paragraph or a couple paragraphs that goes along with our semen analyses now that discusses the results and discusses morphology. So really when a patient says something about morphology, I generally say stop. I'm not concerned about morphology because if the sperm counts are normal and there's a bad morphology, we're never going to take them straight to in vitro for that. And oftentimes if there's a sperm count issue with a bad morphology, there's still a sperm count issue. And you'll never have a bad sperm count and a good morphology. So it never really comes into play in decision making, and a lot of arguments have been made that it should not be reported, and I tend to agree with that. Um, but it's required to be reported.
We got several questions, so I'm kind of going to combine it a little bit. What are lifestyle changes that can be made to improve the quality and quantity of sperm? And does the use of drugs such as marijuana affect fertility?
So there's definitely a correlation between lifestyle factors and fertility. The question is always which kind of came first, and also the question is if you change it, does that necessarily make it better? Poor quality sperm is associated with obesity. It's associated with a lack of exercise, guys who are more sedentary. And it's also associated with both smoking, alcohol, marijuana, and other drug use. The ones that we think probably has the most impact is probably in order of preference, probably other drugs than marijuana, then alcohol, then smoking. Um, in men, there seems to be a threshold before where you see problems. With alcohol, generally a few drinks a week is not an issue. But if a guy is getting up into what we kind of actually term the alcoholic range, 20 drinks a week or more, then that definitely can have an impact. Regular smoking has somewhat of an impact, though lesser. Marijuana is well known to affect concentrations and motility of sperm, as is, like I said, obesity. But with all of these, it is relative to where he came from. If I have a guy who has an extremely normal sperm count, I have guys who use marijuana all the time and it will not affect him at all because his sperm is so stellar. Whereas the same amount of marijuana use in a guy who has an average count or a low count can be detrimental to him. So definitely, if a man is struggling with the sperm counts, and particularly it's most important if he can't benefit from medications. If I can't use medicines to help him and we're trying to see if it gets any better, then definitely relieving all toxic substances. There's not really a concern about underwear use, or rarely is about hot tub use, laptop use. These things do not really have a significant impact. But marijuana, smoking, alcohol can definitely affect it. So in those cases, you're trying to do what you can, and you're eliminating any toxic structures because you can't do anything drastically to help, and it all has a subtle impact. There's sometimes people are wondered about, are there vitamins I can take? And when it comes to vitamins, definitely vitamin supplementation has found to be helpful with sperm numbers. But unfortunately, there is no study that shows an improved pregnancy rates with the men taking vitamins. So I tell people it's not a magic magic issue. I sometimes have guys do that, but again, most of the time it will not change their category they're in from IVF to inseminations or inseminations to intercourse just by taking vitamins. It may help a little bit, and if you have nothing else you can do, by all means, it can be helpful. And when you're eliminating toxic structures, substances, it's thought to take at least a few months. Probably not as long to make full sperm, but probably 2 months to 3 months to see the effect of that. So it's definitely important to eliminate those substances. The one thing that can have a drastic effect are guys that have to use opioids. Opioids, chronic narcotic use, either legal or illegal, can tremendously be associated with low sperm counts. And basically what it does, it shuts down that brain signaling to the testicles so that the brain signaling completely shuts down and sperm counts are terrible. I can overcome that, though sometimes the medicines are a little more involved in order to directly stimulate the testicles. But the opioids are a tremendous issue if the guy's on him.
Okay, so one that was sent to us too says, I am going through cancer treatment. Should I have my sperm frozen?
We see a lot of men that are interested in fertility preservation. I just got called to the hospital last weekend to see a man who was diagnosed with cancer and was debating should we freeze sperm or not. Most any cancer therapy, chemotherapy or radiation, is toxic to sperm. It depends on the type of cancers and how aggressive it is. Harsher things like leukemias and lymphomas They are treated with very harsh chemotherapies that often can completely destroy testicular function over time. So in those people, many times we definitely recommend freezing sperm up front. That needs to be done before the chemo is initiated, but it's something that can be done on very short notice. You could call our office today in the morning and we can freeze tomorrow. It can be done very easy. However, in guys that are in a very sick process, such as leukemia or lymphoma, often the sperm counts are poor quality. But I'd rather have some poor quality sperm frozen than no sperm frozen down the road, because it can take up to a couple years. It can take upwards of 2 years after the ending of the chemotherapy to have counts really level out to see if you have any. And with some harsher chemos, there's definitely a very real chance. It's hard to exactly estimate the chance of having no sperm, but there's a very real chance there won't be any. So freezing up front is extremely easy.
Okay, and the last question we're going to do is how common a problem is male factor infertility?
I discussed earlier that of all infertility cases, it accounts for at least the sole cause in about 35% of couples, and a contributing factor in up to 50% of couples. But in all men across the board, about 7 to 8% of all men have fertility issues, and they never know about it. And sometimes guys can be very stubborn. I'm a man, and I know, and that's why I tell the women, we're going to have to do a lot. The woman is harder to figure out, and the male, we're going to have to do a lot of investigation. And so starting with him is the simplest, easiest, cheapest way. For many guys, it's an ego issue, but I tell them, look, I know it is. Just suck it up, though. It's the easiest thing you can do to do your sample in a cup and look at it. And a lot of times, even if they've had a child in the past, that doesn't tell me anything. That just tells me he had some sperm back then. And especially if it's been more than 3 to 4 years, things can change drastically. And so if it's been more than 3 to 4 years, absolutely, it's the first thing we do before I will put her through any testing, checking the tubes or anything. You need to get the guy checked out. And I jokingly tell the guys, you've been practicing for this test for 15 years, so you can manage, and it's the easiest thing to do.
Perfect.
Well, thank you all for joining us. I hope this has been very helpful, and I just encourage the guys to get checked. We do have some guys that come out and want to get checked on their own. Generally, if the testing goes well, then we can kind of not worry about the guy. Everything is okay, but then we can focus more on the female side. But the male side is a very important aspect, and you have to take that into account in conjunction with the female, because this is a couple issue. This is not a male issue. This is not a female issue. It's a couple problem, and you have to look at taking into both accounts. So that's why I tell couples, I always try to do what's simplest and easiest and cheapest first, but without wasting time, money, and effort on things that aren't going to work. And many couples have already been trying for a long time. And so by far the best thing to do is to get a semen evaluation, and that tells us where to go from there. So if you have any other questions, we would be very happy to see you. Personally, I go to our offices in Asheville, Greenville, and Columbia, and see patients there, and we'd be happy to help in any way we can. I hope everyone has a good night, and thank you for joining us.